other thing is like the only indication flow diverter and there is no transvenous access. The other thing is like fistula persists. Flow diverter and there is no transvenous access. You have to put another fistula persists. Then what will you do? This is an experimental most of the papers they come. This is an experimental most of the papers cannot replace the standard, but otherwise cannot replace the standard, but otherwise good.
Okay, sir. Thank you, sir. Okay, sir. Thank you.
Thank you, Dr. Dikshit, and thank you, sir. Next is Dr. Prabhakaran, presenting on strategic endovascular embolization approaches in brain AVM. I request Dr. Preeti to occupy the front for the next presentation. Thank you.
Good morning, everyone. Today I am going to present a series of seven cases about AVM embolization done in our Radiology in the last 1 year. Myself, Dr. Prabhakaran, and my guide is Professor S. Co-guide Dr. Periyakarapan. This is the first case. It's an old male, 39-year-old male. Already operated for AVM. Now again came with complaints of headache and seizures. Diagnostic DSA revealed resistant AVM in the left frontal region, measuring approximately around 2 centimeter, and in the left inferior frontal gyrus region, non-eloquent area, and supplied by the ACA branch and sagittal sinus. And while taking DSA of AVM, we should keep the frame rate at so that we can separately visualize the artery AVM. This is the 3D images showing the AVM. And after wedging with the microcatheter, we will inject contrast to determine the speed of injection, and we embolized using Onyx 18. This is the post-embolization showing percolation of the Onyx into the AVM. This is the 1 year follow-up DSA. Now the came to a size of 4 mm. Which corresponds to 70% reduction in the size of the AVM, and patient has no complaints. This is our second 20-year-old male with complaints of feeding artery from posterior cerebral draining through deep venous drainage and cortical veins. Spencer Martin grade 3. This case they refer from neurosurgery pre-op embolization, so they could remove the AVM. And this also embolized using Onyx 18. While embolizing, we should keep in mind do under blank road map to check for reflex. This is the post-embolization results. We embolized up to the footplate of the cortical vein. This is the intraoperative showing how much nidus has shrunken, and the neurosurgeon told 90% reduction in blood loss. They didn't even require a blood transfusion during the surgery. So this is the injection method. This case 3 is different from the previous two cases. Case has a very diffuse type of nidus. So it is very difficult to embolize in single city. We planned for a staged embolization. And also this case arterial feeders from all the bilateral MCA, PCA. To PCOM it was supplying. So we thought of embolizing the most prominent PCA. This is the 3D DSA image. We plan for stage embolization. After the flowed into different nidus. When the reflux was more, we just pulled the microcatheter and it started filling the half of the nidus also anteriorly. This is the final run. Showing around 50 to 70% reduction in nidus. This is another fourth case. Old male had AVM in the right parietal cortex with intranidal aneurysm repeated by the arrow. The cases with intranidal aneurysm high risk of rupture. So although this case was less than 3 cm, they were opting for radiotherapy. Because of this aneurysm, the high risk of immediate rupture and patient going for symptoms. So we told and treated only the intranidal aneurysm and sent the patient for SRS. This nidus embolized using Onyx 18. This is the 1 year follow. After patient went the lesion was still 50% still present. But no complaints. Another 17-year-old young patient AVM in the left GC region, and this has numerous supply small from the feeders from mainly supplied by the anterochoroidal artery and PCOM. And we embolized Onyx 18 and marathon catheter and deep venous drainage into the internal cerebral vein noted. This case post procedure developed right side hemiplegia and then semiplegia, and within 6 months he improved symptoms. This is another 9-year-old child AVM in the left quadrigeminal feeding artery from the left PCA and similarly embolized. This is the last case. 23-year-old with history of cerebral hemorrhage and Vermean AVM with intranidal aneurysms as seen in the CT images. And this also embolized using Onyx showing the post procedure CT. These are the summary of all the cases. So the key learning points is embolization can be a standalone treatment. Also can be used for radiotherapy and surgery. Usually the radiotherapy takes 2 to 3 years to work. If the AVM has any high risk of rupture, then we should advise them embolization and visualization. And for surgery also, it reduces and the surgeon can visualize the AVM separately if we do embolization. And for larger AVMs, we should go for staged embolization. 1 or 2 feeding arteries at a time. Most of the time, we use 18 Onyx 18. Mainly AVM. We have not tried this pressure cooker technique. Most of the cases, the microcatheter got well wedged into the feeding artery, and no that much reflex we formed the proximal plug with the Onyx. We didn't use these advanced techniques.
but you have told this, you have told, you have not used, but you have not sometimes actually, sometimes depending upon the flow, you might have strategy and your strategy. On its 18 is used in most cases, but sometimes we need a larger nidus is there, we need more percolation than we may go and sometimes it is a fistula and we are very having that immediate side, then to venous side, then we have to use the septal balloon flow or use the flow or this pressure. You can use this pressure cooker technique. Strategy depends upon the case. For most of the cases, which was the microcatheter.
Marathon microcatheter.
So, what I have observed, what you have shown, the catheter is not wedged in the nidus. Most of the cases, it's in the feeding artery. You have started injecting on it away from the nidus. How do you identify that your microcatheter is in the nidus? Do you know that?
When the venous drainage starts very faster, then we can
exactly. So what you have shown that a lot of feeding artery, then the nidus, and then the vein. So it is mainly in the feeding. This point of time, in this sort of cases, what you have shown, we do not use marathon because you cannot allow any reflux. So your injection will be premature, and that's why in most of the cases you could not embolize. Why your follow-up DSA is after 1 year? Cannot be after 1 year. One of two cases you have the post-embolization DSA. How is it? Those things are very important. So once the AVM is half treated, is not treated. So you may not treat the whole AVM. But at the same point, you have to consult either the surgeon or the radiotherapy doctor, so that you immediately send the patient for radiotherapy. Wait for 1 year. The patient come to you again with bleed. So that's the wrong strategy. This sort of whatever it is, you go for an AVM embolization. In today's scenario, primary aim is to cure. Primary aim is to cure, and not that the surgeon take it out. You will take it out. You do some embolization. This is probably not the right way to go at this point of time. Last 25 years, we are treating. The strategy has to. If you cannot cure with embolization, it has to go directly to radiotherapy or surgery, whichever we feel suitable. So yeah. Otherwise, it's a nice done study. Thank you.
Nice cases. So what is your post-procedure complication rate? How many cases bleed you saw?
Out of this, only one case developed a hemiplegia. Other cases are fine. Only.
What is the natural history of AVM trials? How many percentage of unruptured AVM they bleed in a year? Okay, thank you.
Thank you, Dr. Kirabakar. Next we have Dr. Snehal is here. Dr. Snehal is here. Please have your seat. It will be slideshow.
Good morning. I am Dr. Preeti from Sri Ramachandra Institute of Higher Education and Research. Presenting our 12 years single center on telescopic flow diverters used for complex intracranial aneurysms. The real world data on safety and efficacy of telescopic flow diverters is limited. We have two scenarios: planned elective and rescue telescoping for intraprocedural complications such as flow diverter prolapse or slippage. We have retrospectively analyzed 20 patients treated with telescope FTs. We have analyzed the clinico-demographics, aneurysm characteristics, types of and angiographic occlusion as follows. Dual antiplatelet therapy was started 5 days prior to the procedure. Platelet inhibition efficacy was assessed. The occlusion degree of intracranial aneurysm was upgraded using the O'Kelly-Morata scale. Our imaging follow-up protocol was CT brain was done on the post-op day 1 and 1 month follow-up. CT brain was done and 3 months MRI was done and 6 month follow-up angio was done. The results are like most of them presented with headaches and most of them had hypertension. Our cohort had aneurysm most commonly located in the anterior circulation, ICA being the most common location. The aneurysms were most commonly unruptured and most of them were types. Pipeline FT was the most commonly used FD. The telescoping was most commonly planned in the elective manner. Nearly 2 FTs was placed in 15 patients and more than 4 FTs were placed in a single patient. Adjuvant treatment was done in 4 patients. This shows the types of construct that is proximal extension in which one FD once placed, the second FD is placed proximal to it, and in case of distal extension, once the first FD is placed distal to it, combined in which proximal extension was done, and another FD with another, which means like overlapping FD. The most common construct was like proximal extension. The delivery wire was advanced and the intermediate catheter advanced as much as possible tracking the microcatheter. The first implant in 5 cases. Second same diameter or larger than the first one to prevent a malposition. In all second FT was overlapped for a length of 30 to 35% for the final telescoping construct. Gentle stent plastic wire massage was performed in nearly 3 cases. All the flow diverters placed had a good position with the parent. Immediate occlusion rate was nearly 90% of complete exclusion of aneurysm was achieved in 90% patients in 1 year follow-up and nearly 95% in 5-year follow-up. Neointimal hyperplasia and the follow-up BSA was seen in one patient. Nearly 20% had major complications. 2 patients had re-rupture and one had intraparenchymal hemorrhage and another had antiplatelet non-compliance. Case examples shows an elective telescoping in which combined proximal and distal extension was made using 3 FDs. Thereby achieving OKM area of an unruptured left cavernous ICA aneurysm. This image was a rescue fed flow diverter in case of an unruptured fusiform basilar aneurysm where the first FT slipped into the aneurysm. Hence it was overcome by placing another FT achieving OKM great occlusion. This image shows multiple ICA aneurysms in which the first FT was unable to cover the left ICA bifurcation aneurysm due to slippage into the aneurysm. Hence another FT was placed distal to it. This patient on 7-month follow showed a suspicious slippage of the FD into the aneurysm. On the flow diverter braid deformation. On the angio there was persistent filling of the aneurysm with left M1 MCH due to neointimal hyperplasia, which was overcome by placing another FD distal to this. This shows both the elective and telescoping done in a single case, in which two FTs were placed for an unruptured drain fusosacral aneurysm in the left ICA communicating and bifurcation segment, slippage of the distal FT into the aneurysm, which was overcome by placing another FT distal to it. This patient on 7 month follow had a left MC and presented with left MC for whom mechanical thrombectomy was done with the T3 needles. This was mainly due to the antiplatelet non-compliance. This benchmark study shows our study almost comparatively showed similar results with the Reuters study. Complete occlusion was achieved in nearly 90% in the 1-year follow, and nearly 95% in 5-year follow, which is better than the other studies. Telescoping technical nuances. Avoid telescoping in three segments. Don't lose the wire of the first state angulation, lower microcatheter profile as can combine FD with other stents or hybrid. Sizing of second same or larger diameter of the first segment of telescoping should be at least more than 30%. Avoid telescoping over perforators. To avoid rescue FD place, select FD with good radius. Give adequate forward tension to deploy. Avoid re-entry of microcatheter into adjuvant coiling can prevent migration. But the rescue fellows has brought the problem of ensuring that the exit of first FD is in the inflow or outflow vessels. Higher average neck more than 15 mm is reported as a predictor of requirement for telescoping. Conclusion. Hence, with the appropriate construct imaging follow-up, and antiplatelet and compliance, we have achieved high aneurysm occlusion with acceptable safety profile. This study shows the technical feasibility of flow diverter technique in both elective as well as rescue scenarios. This enhances the flow diversion, radio treatment for complex vascular anatomy, parent vessel reconstruction. Future studies are needed to define the optimal strategies for applying FD's telescoping technique.
Nice cases, but our strategy is to avoid telescoping as much as possible, unless it is very much needed for a very fusiform dianeurysm or type of aneurysm or distal type aneurysm. And so many of the cases, I think many of them would have been done with proper sizing, initial and diverter, and many recurrences could have been avoided if one or two coils rather than waiting for a recurrence and putting another flow diverter. Because whenever we see such a large long flow diverter, simultaneously we put one or two coils, which actually uses a thrombosis also, provides a little support for the FD. But if it may be needed in certain cases, then we do it.
Thank you. It's a nice presentation. See, the single factor why you have to either your type 1, type 2, and type 3 categories of indication was the length. Okay. So it is mainly the length of the FD was probably at that point of time was not that long, but nowadays we have 50 and 60 also, so you can do that. And the real telescoping is your fourth one, where it's a total overlapping. But why you did that? What was the indication of your type 4 telescoping? That one thing I want to know from you. And the second one is that you showed one case where there is a narrowing which has happened because of neointimal proliferation. Yeah. And you have put a second FD, this case. So how do you ensure that your neointimal proliferation will not be even worse after putting a second FD? So do you have any explanation for or solution with pharmacology to have this?
Technology we put actually the
But in our series, what we have seen, if you put those patients continue on dual antiplatelet and very high, statin, they resolve the neointimal
stateless
proliferation.
also
They
happens.
resolve rather than going and
Yeah.
putting upfront one, because most of the cases that narrowing will not be clinically that significant.
But that happened because of the FTBD, flow diverter braid deformation. This was in the follow-up, and it
Yeah.
almost prolapsed into the aneurysm.
It prolapsed into the aneurysm.
It was like flow
Yeah.
diverted into the
Yeah.
aneurysm,
Yeah.
and neointimal hyperplasia occurred in the which was not opposed,
Because of non-opposition.
non-opposition, which was due to
Okay.
braid deformation.
Right, right. So yeah, but all the cases are very nice. And what was the complication actually?
20%
Complication rate.
had major complications, like one had a rupture on the, this is like retrospective study.
Yeah.
Before I have seen
Which
the
one
series.
ruptured? Is the anterior circulation or posterior circulation?
Anterior circulation.
Circulation ruptured. Right. Thank you.
Time's up, sir. Yeah. Thank you, Dr. Preeti. Next, Dr. Snehal. Dr. Seetam, please be ready. And followed by Dr. Sharath.
Good morning, I am Dr. Snehal from JJ Hospital, Mumbai, and I will be presenting on correlation between clinical, anatomical and technical factors associated with carotid artery stenting complications in a single center study. My guide is Dr. Avinash Gupta. Background: carotid artery stenting is a minimally invasive procedure for treatment of symptomatic or asymptomatic but hemodynamically significant stenosis at carotid origin. Very few studies have been published which correlate effects of demographic, anatomical and technical factors on clinical outcomes of carotid artery stenting, especially in Asian population. So our study analyzed effects of these factors on perioperative stroke, MI or death after carotid artery stenting. Purpose of our study is to establish correlation between clinical, demographic and anatomical and technical factors on outcome of carotid artery stenting so that necessary steps can be taken for prevention, early detection and treatment of complications. Coming to materials and methods, 106 carotid artery stenting procedures between January 2021 to January 2025 were included in our study. Clinical and demographic information, anatomical factors and technical factors of the procedure of these patients was collected and retrospectively analyzed. Clinical and demographic factors recorded were age, sex, presence of hypertension, diabetes, hypercholesterolemia, coronary artery disease, recent history of CABG or PTCA, congestive heart failure, smoking, chronic kidney disease, and indication for carotid artery stenting. Anatomical factors recorded were side of stenosis, aortic arch type, calcification within the aortic arch, presence of CC origin stenosis, tortuosity of ICA, angulation of ICA from origin, associated intracranial ICA stenosis, length, location, severity of stenosis, and target site calcification. Technical factors recorded were use of embolic protection device, balloon